Okay, Mustafa, let's go and start this case.
Yeah, Bismillah. 75 years old woman presented to the emergency department with worsening resty pain in the left foot without wound. She is a history of coronary artery disease with two stent placement 5 years ago and surgical hysterectomy for total abdominal hysterectomy and colostomy for the colon resection for cancer. She's taking an aspirin and high-dose statin daily and continue to smoke a pack per day.
Okay, so we have 75. She came to the emergency room. She's in very bad pain, breast pain. There's no wound, no tissue loss. And she has coronary artery disease, 2 stents. She has hostile abdomen. She's taking aspirin and statin, but she still smoke. Okay.
Yeah.
So this is like kind of critical limb ischemia, correct?
Yes.
Is that way how it sounds? Okay. So always they ask you what you're going to do next.
Yes. I will go to take a further history and to do thorough examinations, asking about claudications, previous surgeries, and vascular history. Then I will do full examinations, learning about the cardiovascular examinations and the pulses on both lower limb.
And what you do also on your exam? Something we do in the office.
The pulses and neurological exam to see the sensory and the motor.
Okay. But also don't forget do an ABI. Always ABI should be done in the office only. ABI considered like a bedside test, you know. So when you do any testing, I mean when you examine a patient in the clinic, in the emergency room, you should do an ABI. And you know how to do ABI, correct?
Yeah.
Okay. How many ABI we get in the legs? We
sorry,
get
boss?
how many ABI result we get in each leg?
Ankle brachial index and toe brachial index.
No, what I'm saying, the ankle, ABI, ankle pressure. You get
Yeah.
one number or two numbers. Which one you see? TBI or dorsal? Which one you choose?
We'll choose the highest one.
No, not really. You need to use both. Okay, so when you get an ABI, you get it both anterior, posterior, and dorsal, you know. Because you may have like, I mean, it's different from this one, I'm taking in general. You may have an ulcer in the like dorsum of the foot, which is usually supplied by anterior tibial artery. And you do EBI to posterior tibial artery, which is called normal, but the tibial artery is occluded. So you cannot say, no, it's normal, it doesn't need revascularization. So it's important to know each artery. So usually we get two numbers. In each leg, we get anterior tibial, ABI, and another ABI for posterior tibial, okay? And if you're talking about claudication or rest pain, you choose the highest to decide if it's, but if you have tissue loss, it's important to know each one. But in general, when you do tests, always we do both, you know? But when you divide on the arm, which one you choose, the right or left arm?
The highest one.
You choose the highest one. Okay, so the arm, we use the highest one. But in the legs, we do both, okay? And if the ABI is falsely elevated, then you do TBI.
Yeah.
Correct? Okay. So you did this one. So now the pain in the foot started about 1 month ago. So it's not an acute ischemia, okay? And became so bad that she can only sleep with her foot in the dependent positions. She hasn't been walking much because of the pain. Physical examination is normal except for dependent rubora of the left foot. On the right, the femoral pulse is palpable and the pedal signals are biphasic. Okay?
Okay.
While on the left, the femoral pulse is non-palpable and the pedal signals are monophasic. ABI is 0.6 on the right, 0.3 on the left. Is there any other testing you need to do with this situation?
Okay, we'll do a Doppler scan.
Okay, you do Doppler scan. And duplex scan showed the same things. Like, yeah, you can do duplex scan. Let me see. But these days, what duplex scan is enough?
No, we go to CTA.
Well, let me tell you this position. In this patient, do you need to treat her or not?
Yeah, we need because it's critical. They had a rest pain.
So it's critical, need to be done, right?
Yeah.
So you don't need to waste your, I mean, I'm not saying wasting your time, but the most important for you is CT angiogram to see exactly where the lock is. But arterial duplex is also important because you need something like a baseline to see what's your baseline, you know? So I may order both, but the most important for me is CT angiogram. Yeah. And these days, most people go with CT angiogram because I see where's the blockage. If patient is claudicant, then I don't do CT angiogram. It's not important, you know, because I'm not planning for any intervention. I just go with arterial duplex and keep it as a baseline for follow-up in the future.
Yeah.
But when you have a tissue loss or planning to treat, then you have to get a CT angiogram. Okay. Let's see what happened. CT angiogram revealed no significant right iliofemoral inflow disease, but long SFA occlusion, okay, on the right, with reconstitution of the above the knee popliteal artery and intact tibial runoff. So on the right, you just have SFA occlusion. On the right. On the left, the common iliac artery has a short segment occlusion, and external iliac artery and left common artery are severely diseased. So you have disease in the external and common femoral occluded left common iliac artery. Also, SFA is occluded, with reconstitution of the above knee popliteal artery with no significant infragenicular disease. How do you interpret this finding and what would you do next? Remember, her symptom in only one leg, correct?
Yes.
On the left leg. This is her symptom. She has no symptom on the right. Okay?
Yeah.
So with this finding, what do you think is going on? What's your plan?
She has a acute on top of chronic due to thrombosis.
Okay. I will not say that. I will not say that because he told you that it's been there for 1 month, right? I read that somewhere. The pain in the foot started about 1 month ago, you see?
Yeah.
So if she came suddenly, if she was okay, and suddenly, like if she has long history of claudication and suddenly come to the ER with severe pain, it's acute on chronic. But if she's been worsening, this progressive disease. So it's just a critical limb ischemia. I will not call it acute on chronic. This is critical limb ischemia. It's just getting worse slowly over 1 month. Okay. But if he was like slowly, like she has a claudicant, slowly getting worse, and suddenly get like overnight, get suddenly like cold leg, then acute on a chronic. Okay. So this is critical limb ischemia, really. We call it critical limb ischemia. So what's your plan on this patient?
Go for endo.
Tell me what's the plan? I mean, we're going to fix what you need to be because they want to understand. What's your plan? I mean, what's endo for what? What going to fix? What going to do? Tell me what you find. What is that meaning? This is what they want in the exam to understand. Did you understand the CAT scan? What going to treat? Which part are you going to treat? You treat everything, the right, the left, inflow, outflow. This is what they want to know.
Okay. She has the problem on the left, is it? Yeah.
Correct. She has a left leg, rest pain. This is when she came. Okay. Let me summarize that again to you. On the right side, she has SFA occlusion all. On the right. On the left, she has common iliac occlusion, disease external and common femoral, and SFA occlusion. Okay. So first, you should tell me, you know, what we're going to do. So you tell me first, on the right, she has SFA occlusion, but she's asymptomatic. So I'm not going to touch the right leg. It's the first thing you tell me. Correct?
Yeah.
So forget about the right leg. I don't care about the SFA occlusion, popliteal occlusion. I don't care. Even if common femoral artery is occluded, I don't care because the right is asymptomatic. So you can tell the examiner the right leg is asymptomatic. So whatever is disease there is not my priority now. So I'm not going to treat it. So I'm going to concentrate on the left leg. Okay. Yeah. The left leg, I have two problems. I have inflow and outflow.
Oh.
Right. You have
Yes.
two levels, inflow and outflow, correct?
Yeah.
So now you look at, go ahead.
The inflow. We'll deal with the inflow first by endo, then the outflow I will do FIM-BOP bypass. So the priority now for the inflow now. Go for from the brachial to do thrombolysis, catheter directed. Then after that we'll manage the lesion, either by stenting or.
First, Mustafa. First, yeah. I didn't tell you how you treat it. So now you get yourself to trouble. Because I didn't tell you how to treat it. I say, what are you going to treat? I didn't tell you how you treat it, you know? So I would not. I told you what your plan. So first we talk about the right leg, right? Now you tell me you're going to treat the inflow and outflow, correct? This is what I understood?
Yes.
Yeah, this is wrong. They're going to fail you on that. I don't know to fail you, but this is wrong. Why is that? What is her main symptoms? Is rest pain or tissue loss?
Rest pain.
Rest pain. When the rest pain, do we treat the inflow or outflow or both?
Inflow. Inflow.
Inflow only. Yeah. Only. Okay. Yeah. So when you treat with a rest pain, then we treat inflow only. If she has a tissue loss, then they have to treat inflow and outflow.
Oh,
okay. So they have to be careful. So here he told you only rest pain. Even if she has an inflow and outflow, my plan to treat only the inflow. Okay.
He had SFA
because if they get blood flow to the profunda and common femoral, it's more than enough. We'll get you off the rest pain. When you get a normal blood flow to the profunda, it will get you out of rest pain. It doesn't matter how the SFA is done. Okay. So your purpose now to get normal blood flow to the profunda. The moment you do that, you get patient out of rest pain. Okay.
Okay, boss.
So how you deal with that? How you treat that? Read what the story. Huh? Sorry?
Via the thrombolysis, catheter directed thrombolysis via the brachial artery.
Thrombolysis of what?
She had a.
But then why thrombolysis? Why you still presuming it?
Because the insidious onset of the symptoms, maybe it's disease, then they get thrombus slowly till become occluded.
Well, you are still insisting that this is an acute on chronic, which is not. Why you keep telling me it's acute and chronic? It's not acute and chronic. This is a progress of the disease.
Okay.
You see, he did not come suddenly overnight. If he come overnight, it's different. He said he's been there for 1 month. You know, he said that very clearly here. He said the guy has been there for 1 month. So you don't treat him as acute and chronic. This is a progressed critical limb ischemia. So the common iliac artery, common femoral artery, external, all is disease. The thrombolysis has no role here. Now, if you do thrombolysis, you just put patient through more bleeding. Even you may not able to cross it. This is not a clot, you cross it. This is occlusion. You're not able even to cross it. So how are you going to do thrombolysis? Okay.
Okay. So we'll go for endo via the brachial artery.
Why don't go through femoral? Why want to go through brachial, not femoral?
Because there is an occlusion of the common femoral.
Okay, and this occlusion, you think is a clot or atheroma?
Atheroma, most likely.
Okay, so how is going to go through the brachial is going to help?
It's good for pushability and trackability.
No, because no. But this is when you have a common femoral artery. Okay, so if you cross the common and then you're going to go to the common, okay? And after that, you have SFA occlusion. So where's you are going to go? Because you have common iliac occlusion, external is disease, common femoral is disease, SFA is occluded. So this is not a place for endovascular. The moment you see common femoral artery disease, especially for you guys in the exam, this is not the place for endovascular, period. I mean, don't tell me the new data and stent and everything. In exam, you have to be on safe side. You have to tell them the more basic things. Common femoral artery disease, the only treatment is endarterectomy. Okay? So this patient, you do a hybrid repair. You do endarterectomy is a common femoral artery. Then you go retrograde and you try, and then you try to stent the common iliac artery and extend the iliac artery. Okay? But as far as you see, the moment you see the common femoral artery is disease, the moment you see the common femoral artery is disease, then that means you start open repair. Okay, this is the rule. Okay, so anytime they give a scenario, common femoral artery is disease or occluded, then you start endo and then either do bypass or it starts open and then continue with a bypass or endo. It's up to you. But this one in general, we do endo for common and external iliac. So you do endarterectomy in the common femoral artery, and then you go retrograde, try to cannulate. Okay.
So I have a question here. If it is difficult to go retrograde, or there is a difficulty to pass the lesion, the common iliac.
Yes.
So we can go from the brachial, no, and go through and do through and through maneuver by snaring.
You can. Yes, no problem. You can do whatever you want, or you can go from contralateral side. Okay. I mean, you have two options. Either go from contralateral side to treat, or you can go from brachial. Okay. But you have to fix the common femoral artery first. Okay. So how you do the procedure? Yes, you have to come in the endarterectomy from the blasty, and then you have to tell me what the step, how you do the hybrid repair in this case. This is a very common case, by the way. I mean, you see it in your daily basis. So it's important for you to bypass this station, because this station more than aorta important, because aorta you may see it once a day, once every couple of months. You can send him to the like high center for repair, you see. But for examiner, this is your daily practice. So for the examiner, this scenario is the most important for you to bypass you. So he wants you to exactly, because you see this out every day, how you can approach this one. So he wants to do step by step. So you decide to do a hybrid repair on this patient. So how you start? Explain to me the procedure. This is a question, I think, next option. Let me see what the next question.
Okay.
Let's see. The workup is negative. Describe your operation. Describe your operation. Here you are. Yeah. So how you describe it?
Okay. It's the patient. So we'll start from this incision in the left side, 10 to 12 centimeter below the inguinal longitudinal. Dissect down till they reach the femoral, the common femoral artery, profunda, and SFA.
Just a second, Mustafa. You start 10 centimeter below the inguinal ligament. You start below 10 centimeter. Why is too far from inguinal ligament? I mean, common femoral artery is exactly start at the inguinal ligament. So why go too low under the inguinal ligament? You have to start from inguinal ligament and go down. But you don't start 10 centimeters too far. Then you'll be an SFA.
Yeah, okay. I just
so you start.
Make a mistake.
You start. Yeah,
from
you start at the inguinal ligament and you go down. Yeah.
Yeah.
Okay.
Then dissect down till we reach the common femoral, superficial femoral artery and the profunda. Then loop it and control it. Then we'll do longitudinal incision from the femoral artery till the bifurcation. Then we'll do an endarterectomy by the remove of the plate.
Remember, Musa, in the exam, okay, everything is counting against you. Like you did not give heparin. You say this is B negative. Don't forget that. I know you do it in the real life, but the exam, he presume you're not giving heparin.
No.
Because he's going to tell you, okay, after you finish, you're thrombosed. Why? And then you get confused why thrombose, but really very simple. So don't forget, before you clamp, you have to give heparin. Okay?
Yeah.
All right.
I'll
So
get
let's
the
continue.
heparin.
So give heparin, you clamp, you open, and then?
Then we'll start to take the plaque out from the
Okay.
lateral sides
Okay.
and from the profunda also. Then
Okay.
I will
Okay.
tack it distally if there is
And
extension in
clamp.
the left A. Okay.
Okay.
Then I will patch my flushing and start to closure the arteriotomy by the venous patch longitudinally. Then I will put my sheath over the patch. Okay. Then travert the wire retrograde to reach the aorta after the crossing the lesions. Then
How do you know you're
I'll
in the
do
aorta?
aortogram.
How do you know you're inside the aorta?
Uh,
How do you know what your distal point? Because if you do an
uh,
angiogram from below, you don't see the aorta. So how are you going to see the
yeah,
aorta to know this is the end of it?
yeah, I will insert a catheter and do aortogram
From where, catheter?
at the same side over the wire
From
after
where?
the crossing. After the crossing the lesion, I will set a catheter over the wire. Then I
No,
will.
no, 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 just a second. But you're going to cross the lesion to where? I mean, you do angiogram, you don't know where's the aorta. So how do you know you cross the lesion? You cannot just
Yeah,
go
oh,
blindly like that,
I
right?
get it. Yeah, I
You
get
have
it.
to see
I
where
will
the
count.
distance. Yeah.
Yeah, I will count the vertebrae. Okay. See the renal.
But where you get the catheter from where? You get my point? You see what my question?
Yeah.
My
Yes.
question is that when you want to cross it, you have to see your distal end, right?
Yeah.
So your distal end is the aorta. So how you can image the aorta? Because if you should die from below, it's an occlusion. You can't see the aorta. So how do you can see the aorta? So you know this is your distal area, so you can stop at this area. You cannot keep going dissection up to the renal, above renal. So you have to do an aortogram. But how you do an aortogram from where?
Take from the other side, but there is a
Yeah,
femoral, it's not palpable.
other side femoral is not palpable. No, it's palpable. Femoral pulse is not. He said it's not. No, it's phasical. It's common femoral is palpable on the right.
Oh,
No significant right iliofemoral inflow disease on the right. So you can go from the
yeah.
right, put a sheath, go up to put a big tail, so you know where you end, do an aortogram, then you start your recanalization, okay? If
Okay.
the right is disease, you go from brachial artery all the way down, you put your big tail, and shoot an angiogram. But you cannot cannulate an occlusion without saying your distal end, the aorta. You understand?
Yeah. Yes.
So you have to do this first, okay? And then, how do you know you cross it? And then you see the end, and your catheter went all the way wire, but could be subintimal. So how do you know you are inside the lumen?
I can insert a big tail in
No,
the wire.
no, you cannot do that like what you do in the aneurysm, because you're back in your dissection. You see the big tail, and you start rotating the big tail. You can cause the huge dissection with aortic dissection. It's very risky. We don't do that. Okay. First, you have to get the feeling with the wire. The wire has to go straight. It's as far as the wire is still looping, that means you're on subintimal. The wire has to go straight. The moment the wire goes straight without any resistance, then you are interluminal, but it's not enough. Then you put a catheter over the wire all the way inside the aorta, and you take the
Yeah.
wire out. You have to see blood. If you don't see blood, that means you are subintimal. Don't inject, because if you are subintimal and you inject, you cause dissection. If you don't see blood and inject, you cause dissection. Aorta is very dangerous, so you cannot play with it because you can get dissection. Okay, so you put your catheter, you take the wire. If you see blood coming out, then you are in true lumen, but not 100%. Then you need to confirm it. Then you do an angiogram. If the angiogram showed you are intraluminar, that's it. Now you are sure intraluminar. Then you put your wire back. And then you start endovascular treatment, whatever you want. Okay?
Yes. Okay.
But my question, why don't do that before put a patch? Why put a patch and then you put the sheath? Why don't just put the sheath first, and after you finish everything, you put a patch?
We didn't have if will be clamped and there is no outflow.
This is correct. So it's better always to put a patch, because if you do the sheath first and you put a stent and no outflow, this will be thrombosed. So it's better, as you said, to put a patch, and through the patch you put your sheath and you do endovascular. So when you do a hybrid, first you do endarterectomy, you put a patch, and then you access the patch and you do your endovascular. All right?
Okay.
All right, let's see what next question here. What if you couldn't re-enter the true lumen when attempting to cross the iliac artery and you remain sub-intimal? We talk about, you said you go from other side or you go from brachial, correct?
Yes.
But if you cannot get through from the contralateral side, we go to brachial. We said that.
Yeah.
Let's say you were not able to cross the lesion endovascularly. What will you do with the left SFA occlusion? Let's say that you're not able to cross the lesion in endovascular. First, what you do? Let's say you cannot cross it, not from right, not from the left, not from above. What you do?
Fin bypass.
Correct. You do fem bypass. Okay. What about SFA occlusion? Are you going to open it, or what's the plan?
We'll go fin bypass.
Mustafa, we just said we don't need the SFA bypass. Why need this SFA? We said it's a rest pain, right?
Yes.
So we should leave it alone. Why need to do fem pop?
We'll leave it. Yeah, we'll leave it. Concerning about the bypass, maybe it will get thrombosed if it's not good back.
No. Profunda is more enough. Profunda is better than SFA, by the way. Profunda is the best artery in your cyst, in your body. Sometimes you see SFA is occluded, externally occluded, the common femoral aorta is occluded, but profunda is still open. Profunda is the best artery. So if you have good flow to the profunda, you are fine. Okay? Don't worry about SFA. SFA is useless. Okay? So if you have wrist pain, as we said, if it has a tissue loss, then you have to open SFA. All right, next. What if the indication for non-healing pedal ulcer would see? Now he tell you, if you give you this one, then you have to do an SFA, either endovascular or fem pop. Okay?
Okay.
Would you use vein or prosthetic as a conduit? هلا هو ال SFA is occluded but reconstitute above the knee. شايف قال لك هون above the knee. So if you have SFA occlusion just above the knee, if you do fem pop above the knee, do you use vein or prosthetic?
It's same.
It is the same. So people, the patency is the same. But in general, I always prefer to do a vein. But the patency are the same. Okay? Let's back up and say you had to do femoral artery to femoral bypass, as well as femoral artery to above the knee popliteal artery bypass. And she now has a bubble pulse in the left foot. Okay, so you did it for tissue loss. When she wake up from surgery, she now has a wrist pain in the right foot that she didn't have before. So now before she didn't have any problem. Now she wake up, she has pain, wrist pain in the right foot. Why is that?
Maybe still. Or atheroembolism distally.
You see, Mustafa, I always guys tell you the same story. Don't volunteer information. You get yourself to trouble. This is a steal. Why is atheroma? Now I can tell you, okay, why atheroma? Where is it coming from? Aorta is clean. Where is the atheroma came from? Unless you tell me it jumped over from the other side. Could be possible. But don't get yourself to more trouble. Unless he asks you what else, then you tell him could be emboli from the other side. When I'm trying to do like ballooning or stenting the common iliac artery, small clot jump over to the other side, could be possible. But the most common is Steele syndrome, because you did fem pipe bypass. If you didn't fem pipe bypass, will not know Steele, because both SFA are included. Because you open the SFA on the left, now the flow resistance is less on the left, so the blood will go to the left, and she has SFA occlusion on the right, then she may get a Steele syndrome. Okay?
Okay, yeah.
Okay, the exam has changed to bubble femoral pulse and monophasic pedal pulse. ABI is 0.4, and the duplex is straight widely patent femoral vessels and crossover bypass. There is to and fro flow in the box SFA with a mid-SFA occlusion. Read this finding. What do we do about it? What if it doesn't normalized? This I'm talking about Steele syndrome. So if you get the Steele syndrome, what are you going to do? And she has mid-SFA occlusion.
Okay, I will try to start conservative with anticoagulant, and if not improve, try endo.
Okay.
Facilitate the
Okay. You can try consultative first to see if it improves. Does not improve, then you do endovascular, either recanalization or you can do FEMPOP bypasses. Okay. Any question about this scenario? Any question from anyone?
Sarah, I want to ask about this case. Sometimes we cannot.
Yes.
There is difficult cannulation of iliac lesion. My question is, first do endarterectomy or crossing the lesion?
Say that again. If you cannot cross it.
Sometimes difficult to cross the iliac lesion.
Correct. So what the question?
The best scenario, doing endarterectomy first or crossing the lesion first?
Okay, I get your point. No, always you have to do the endarterectomy first because this will not change your approach, you know. Because if you're going to do FEMPOP, bypass, you're going to do it on the patch anyway. You see? So you still have to do a patch. So I always first do endarterectomy first. Because if you cross it and you didn't do endarterectomy first, then be a problem because how are you going to do endarterectomy? Why will be in your way? And you cannot stent the SFA, the common iliac artery. If you stent it and common femoral artery is still occluded, you're going to thrombose the stent. So common femoral artery has to be open first. So you open common femoral artery, you put a patch, and then you cross the patch with a sheath, then you try. If you cannot, then you do FEM bypass. This is the consequences.
Okay, clear. Thanks, boss.
Okay. Any other question?
Yes. If the common femoral artery is just diseased and not occluded, can't we just try angioplasty and not endarterectomy? Ballooning?
As I said, I mean, in the exam, it's better to be on the safe side, you know, because a lot of controversy about this issue. In the exam, you have to be, guys, very classic surgeon, safe surgeon. So if you tell your disease, common femoral artery, I think tell him endarterectomy, I think. Because if you do tell him angioplasty, atherectomy, he may not happy with that because he may be from the old, you know, school. He doesn't like this endo for common femoral arteries. A lot of controversy about this one. In the exam, don't bring controversy. Okay? And try to be straightforward. Try to be safe.
But away from the exam, this is a good option, right?
What is that?
Just doing the ballooning of the common femoral artery without, if it is diseased, and not endarterectomy.
No, not really. It's not a good, no. Because common femoral artery is surgery. Don't come to the, I mean, what you do, I'm telling you, in the exam, you don't have to be updated. You don't have to give him controversial things, you know, because what's going to tell you? He's going to tell you, okay, you're going to get dissection. What do you do now?
Okay.
So he's going to get you there. Common femoral artery, disease common femoral artery, be on safe side, endarterectomy. You see, if you do endarterectomy, like if you have an SFA occlusion, okay? If you do FEMPOP, nobody, you know, tell you why did FEMPOP. Nobody. It's okay. Even if you don't do endovascular first. I say, okay, I want to do FEMPOP. If he tell you why don't do endovascular, tell him I don't have experience in endovascular. I prefer FEMPOP. It's safe, you know, it's safer. Less chance of embolization, better patency, you know, cheaper for the patient. So I go with that. Nobody. But if you go with SFA and do ballooning, then get dissection, then thrombosis, then embolization, you get yourself to trouble, you know. So there's a spaces. So yes, you're doing the vascular, but if you do the vascular, try to do something like fit, you know, everyone agree on it, you know. So common
Yeah.
femoral artery phalangoeplasty stenting is not 100% approved by everyone. So I will not go through this. Anytime I see common femoral artery stenosis, even stenosis, I'll say I will prefer doing endarterectomy with a patch. Easy surgery, good outflow, good result. If he tell you a patient is very sick, very obese, COPD, coronary artery disease, say, okay, then I may try angioplasty, but very careful atherectomy device,
Okay.
But it's not your first choice, unless he push you to this situation, okay?
Okay, thank you.
You're welcome. Any other question?
Yes, please. Regarding
Yes.
this, if I have wrist pain and tissue loss, we
Mhm.
agreed about improving the inflow. What about the outflow? What I will do?
Yes, you have to fix it. If you have a tissue loss, then inflow is not enough. You have to fix the outflow. In this scenario, you're already open.
Yes,
You
yes.
can try endovascular. If it's a short occlusion, I can try endovascular. If we cannot cross it, or if it has a long occlusion, then FEMPOP pipings. You get my point?
No. The
Mhm.
outflow, what do you mean by outflow? The retaining blood?
Okay. Inflow, inflow is that being up to the profunda, like common iliac artery, external iliac artery, profunda, and common femoral artery. This is called an outflow. Inflow. Outflow is the SFA, popliteal, and tibial artery. Okay?
Yeah, agree.
So
Okay.
basically, when it comes to wrist pain, he has to have an inflow. You cannot have wrist pain with completely open, common, external, and profunda. No way. No way you can get wrist pain. You have to have an inflow to get wrist pain. So basically, wrist pain has to have common occlusion or stenosis, external iliac artery, or common femoral artery or profunda problems. Because if you have normal flow to the profunda, you should not get a wrist pain. So I'm going to tell you he has a wrist pain, that means he has a mainly inflow problem. Then he have a tissue loss, then he has also outflow problems. You have to fix them both. But if it's only wrist pain, if you fix the inflow alone, it would be enough.
Yes, thank you.
Okay. Any
Yes,
other
Prof.
question?
One
Yes,
question.
please.
Regarding this patient, if
Uh-huh.
I need to evaluate more, can I do profound popliteal index? Then I will tell if it is not more than that or less than that to determine the need for the further
Need for bypass.
reconstruction. Yeah.
Really, the index, usually they do to decide to go above or below the knee, not for FEMPOP. They do it if you decide to go, above the knee or below the knee. This is the main, because sometimes you fix the inflow and you have popliteal artery occlusion, okay? And popliteal artery is the worst thing for endo or open, So you have to be 100% if it's needed or not. Then you do the index. If the index is low, then you have to fix popliteal artery. If it's not, then you don't have to fix it, especially if he has a wound. If he has a wound, it's not for wrist pain, it's for wound. But in general, again, don't volunteer this information unless you know exactly how you do it, what's the normal variation. If it's abnormal, how you fix it. So don't get yourself to this one unless you're sure you know how to talk about it, because he's going to take you this track, this direction. And I will not volunteer this information. Again, in the exam, giving extra information is not helpful. Extra information will not give you extra credit. It may, if you get to trouble, it take your credit. But if you say something positive, it's not in the exam, will not give you an extra. You get my point? Like this one, if you tell me FEMPOP, you take like 2 points. Okay? But if you tell me I do FEMPOP and I do the femoral popliteal index, you still get 2 points, not extra. But if you tell me I do femoral popliteal index and I found you don't know how to interpret it, then I can give you 0. You see how the exam? So you have to be smart in the exam. Just give him what he wants and stop. If he wants extra, he will tell you. You just tell him, if you want extra, he tell you, okay, can you do something else? Can you, he has popliteal artery occlusion. Do we have to fix it? Is there any way to evaluate it? I mean, he will ask you. So just answer the question exactly and wait for him to start the next question.
Okay, thank you.
Okay. What next? All right, let's go to the next scenario. Is Abdurrahman here or not? Or Uthman? Abdurrahman موجود?
Yes, bro.
Okay, Rahman, let's go take the next one.
Okay.
Let's see if it's a good case or not. Yeah, let's try this one. Okay.
Okay. A 50,
What is
a
that? Foot
55 year.
ulcer. This is very close to the next case. Let's take the one after that.
Okay.
Because this is the same ulcer. This one, COVID. Okay, let's go with this one.
Okay, a 45-year-old man with no prior medical history is admitted to the intensive care unit with COVID, pneumonia, on rounds, and the patient endures severe right leg pain, and the team cannot find pulses. After initiation of heparin drip, vascular surgery is called to evaluate the patient with concern for acute limb ischemia. By the time you see him, it has been 6 hours since the onset of the symptoms.
Okay, so what do we have here?
Patient of acute limb ischemia with
Acute limb ischemia, okay? It's very
with,
obvious. 45 is no medical problem. He was normal, you know, and has COVID. You know, COVID get a lot of acute ischemia.
yes.
But the most important, he gave you 6 hours. Why he gave you 6 hours?
It passed the duration of that the leg is accepted to ischemia. Is profound ischemia.
What? So what
It
6
may be-
hours mean? What? So what you have to do?
If I do intervention, I consider fasciotomy.
Yes, so this things to do fasciotomy, okay?
Prophylaxis fasciotomy.
All right. So the first question, what are you going to do next first? So patient came, they call you, has acute limb ischemia. What are you going to do next?
Okay, I will evaluate the patient full examination and neuro examination to know rather for stage.
Correct. But now he's going to ask you, what are reservoir stage? You have to tell him, okay?
Okay, yes.
Okay. So if he tells you, you know what stage 1, 2, 3, how to tell him.
Yes.
And to be A and B, you have to know all this. Okay.
Okay.
There's no prior history of codification. The pain has been constant for the last 6 hours. He has palpable pulses throughout his left leg extremity. So the left is normal. The right, absent pulse with decreased motor and sensation. Okay? So this is what? What do you know what's Clapper? 2B.
2B, yes.
Correct. Sorry. This way, not this one. Okay. There is a faint monophasic posterior tibial signals on the right foot. What do you do next?
Okay. This case is 2B. It is urgent intervention. It needs urgent intervention. I will do thrombectomy. He has absent pulse, FN femoral, yes, isn't it?
You don't, wait, you don't ask the examiner this question, okay? You read it again because they give you a paper. Yeah, and you have to concentrate. That means you're not following him, so it's not good. So be careful.
Okay.
So when he talks, remember everything he said. So right lower extremity has no pulse. Yeah.
Okay.
All lower extremity.
As the patient starts the heparin anticoagulation, I will prepare patient for femoral thrombectomy.
Femoral thrombectomy. Okay. What if it's iliac occlude? How do you know it's a femoral iliac?
I can go puberty catheter up and down.
What if the aorta is occluded?
Sorry. I will order urgent duplex, or I will do intraoperative conventional angiography to evaluate the.
Just a second. See, because every word, this is how the exam, they're watching every word you're saying is going to stop you on this one. It's the reason why when you're in the exam, be careful everything you say. You said I do a duplex ultrasound, correct? Why? How's going duplex ultrasound to help you? I mean, what extra information you get from duplex ultrasound? It's nothing. There's no flow.
Nothing. Yes.
You know, it's occluded, so it's useless. It's a wasting of time, especially it's acute ischemia. Timing is important. Okay.
Yes.
So I'll not do that. Okay.
Okay.
So this way you could just go to CT angiogram. because you want to see how's everything, how's the aorta, how's the iliac, maybe the aneurysms there, you know, embolize, you know.
But
if you don't have CT angiogram, I understand you can take him for thrombectomy and do an interruptive angiogram. But in general, in normal situation, you do a CT angiogram. Of course, CT angiogram should be done. Listen, if you can take 2-3 hours to CT angiogram, then no, don't do that, you know.
Okay.
But we are presuming you are in a hospital, you have a good, you know, support, you have good CT scan, you get emergency CT scan, you know. But even though in real life you can open without CT angiogram, you know why? Because he has the femoral pulse on the left leg, right? So that means the aorta is open. Because the only thing I'm worried about the aorta, because the aorta is occluded, I don't know where the end of it is so difficult. But when it's iliac already occluded, I know that thrombus there. So as far as I have a pulse on the other leg, so that means the iliac is occluded, but the aorta is open. So then I can proceed without CT angiogram. But it's not the answer in the exam. In the exam, this patient come like that, I'll do CT angiogram. I want to know, you know, my inflow and outflow and where is the blockage, you know, how to treat it. As far as you tell him as can be done as soon as possible, because I don't want to delay his ischemia, his 2B, you know.
Okay.
So it's the way you answer. Okay. So did a CT scan to make thrombosis of the right common femoral artery, minimum opacification of the SFA, occlusion of popliteal artery and crural artery. What's your interpretation of the imaging and plan for treatment? How you can treat this patient?
Right common artery, minimal. Okay. Occlusion of popliteal artery and crural. Okay. The interpretation of CT patient, I will go for femoral thrombectomy.
Okay.
And then I will after ending of the procedure, I will do conventional angiography. If it is if not successful thrombectomy, then I will administer intraarterial thrombolysis.
Okay. Again, you gave too much information because you presume it's not successful. You presume you did this one. He didn't ask you about if it's successful or not, you know. You do thrombectomy, but how do you do it? You didn't tell me. Now I want to do it through the femoral, you do it through popliteal, you do it. How you do that thrombectomy? Describe to me procedure. Let's go next one. You tell you, okay, how do you do the procedure?
Okay, I will do through common femoral artery.
Tell me, I do long incision, expose the common femoral.
Okay.
You have to tell me the details. Is that okay?
Okay.
In the oral exam is practical. They want to know your surgery because it's the whole idea from oral exam. Two things from oral exam. First, you want to know that you use your knowledge in the real life. You can apply it. And second thing, you know how to do it. So everyone, you're going to ask you how you do it. They want to step in details for surgery because they want to know if you can do it or not, or how you do it. Yeah. So how you do it?
I will do longitudinal incision midway between the anterosuperior leg span to symphysis pubis. And after dissection, I will find the common femoral, profunda, and SFA.
Okay.
Then I will give heparin therapeutic dose.
How much?
8 to 100 international unit per kg until activated partial thrombin time to be 250. Then
ACT. Okay.
Then I will open longitudinal incision, transverse arteriotomy. If common femoral artery healthy, I will do arteriotomy transverse.
You said if. Do you think this artery will be healthy or not healthy?
According to
healthy, right?
interpretation, yes, healthy.
No, you cannot tell from outside because artery. But this artery has no claudication, has no history of claudication. So he has normal. His other legs artery is normal, so he has to be healthy artery. And a second thing, you already did the CAT scan, so you know if there's any calcification. So you have to make a decision before, not on the table. Okay.
Okay.
So it's healthy artery. I do transverse incision and
Okay.
do a Fogarty, right? What's
Fogarty.
Fogarty number? You have to know what's the number.
I will start with a large one, five French, up and down.
5.
4 or
5
4.
is big. Yeah, 3 or 4 for the iliac. Don't go more than 4. Yeah, 5 is for aorta. Too big. Yeah.
Okay. 4.
Okay. Okay.
Then after inflow correction, then I will go SFA for 3 French Fogart until down, until I find the good backflow. Also, I will go for profound thrombectomy. Then I will do finally final angiography to see if there is a crural vessels patent or if not patent.
What do you expect? Will be patent or not patent?
Because Fogarty will go directly down to the peroneal. Maybe if I go wire of the wire Fogarty thrombectomy catheter, this will help me. But if it is Fogarty alone, maybe posterior or anterior tubular artery still remain occluded. So I will check angiograph.
Okay. Again, in the exam, you have to tell them what you do, not what you read in the book. Okay. It's going to ask you, have you ever did Fogarty over the balloon, over the wire? How you do Fogarty over the wire? You see? So if you don't do it, I never did, don't get to that direction. Okay.
Okay.
Again, in the exam, imagine you are in your real life. Don't try to answer books. Try to be in real life, real scenario, and what you're going to do. And like if you get the same case tomorrow. Okay. First, when the crural artery is occluded, no way can clean them up from above. No way. Because as you said, the Fogarty will go to the profunda. No way can go to anterior posterior tibial artery. And to go with catheters and wires, yes, but you have to be really in high center. So most people, when you have a crural vessel, then you have to open popliteal artery below the knee. Okay? So in general, if common femoral artery is occluded, you have to open from above, and crural occluded, then you have to open from above and below. If it's only SFA is occluded and crural occluded, then I open from below, I can do SFA from below. I don't have to do crural.
Yes.
But this one has both, so you have to open both. So you open the profunda, clean it up, then you do incision below the knee, expose the popliteal artery, try the incision, do embolectomy, selective embolectomy for each artery. Okay?
Okay. The good answer.
And then you do an angiogram.
If I do venal angiogram and I see it's not successful thrombectomy, then I will open popliteal, isn't it?
No, because it will not be successful. I'm telling you from now. So don't wasting your time. Because no way you can clean up 3 artery from above. Unless if you have popliteal occlusion is okay. If you have popliteal and then the crural is open, is different. But if a crural are thrombosed, no way you can clean it up from above. So you have to open below the knee. And I told you, if it's a common femoral artery is already open, I even start from below the knee. I don't even go above the knee. I start right away from below the knee, if the common femoral artery is open. Because the problem, even you can do thrombectomy from up below for common femoral artery, but you cannot do from profunda. Profunda is very important. So you have to do it from the common femoral artery for profunda. But if the profunda and common femoral artery is open, then I'll do everything from below. Okay.
Thank you. Okay.
This is in the exam. In real life, it's different. Real life, we now do mechanical thrombectomy because it's very quick. Before we said we cannot do endovascular because thrombolysis take 24, 48 hours, But these days, you can do with a mechanical thrombectomy. It's like a surgery. But again, don't mention that the exam. The exam is different. Exam, be safe side, do with surgery. Okay?
Okay. If he asks me thrombectomy pharmacomechanical, which one is best below knee?
Tell him no. If I talk about thrombolysis, tell him now it's 2B. It's too late, I think, because my 24 hours. Then I will know. I prefer open thrombectomy. Okay,
mechanical.
Especially this is mechanical. Mechanical is different. You can try it. Yeah, you can do mechanical, but let's not be. Don't volunteer. Let him ask you this question. Okay, for you, you do an open. Okay, if he asks you any other way as anything, you can tell him, okay, mechanical thrombectomy. If I have, like Penumbra or Rotarex, whatever, then you can do it. Okay, you can do mechanical thrombectomy. What else? And then at the end, what do you do at the end? What's the procedure?
I close the arteriotomy if then I will do prophylactic fasciotomy.
Okay. Which compartment?
4 compartment.
Go for it. Okay. Let me ask you how you do it. Yeah.
Two incision lateral
Yeah.
medial with 4 compartment. Anterior
Okay. This is
lateral.
important. All right. So you do all this 4 compartment. Okay. Let's see what they said here. Discovered surgery said, what if there's no pulse at the end of the case? You did everything, there's no pulse. So what do you do?
After ended the operation?
Yeah, I mean, you finish the surgery and still no pulse.
I will go
I mean, you need a WC because when you do leg, this is very important. The leg ischemia, you need to save the leg, okay?
Okay.
Sometimes people, the artery go to spasm, especially if it's a normal artery, when you do embolectomy, you know? So you don't have to have a normal pulse, but you need a signals. If I get the signals only in one, especially if you do thrombectomy and you do angiogram, everything looks fine, no more thrombus, or you cannot get any more thrombus, that's it. You just need, you need to get the leg. Then you get a Doppler. If you see signals in one artery, that's enough. You just need flow to the leg to keep it alive. Okay?
Okay.
So if there's no pulse at the end of the case, then I get a Doppler. If I see signals in one of the artery, I think it's okay. It was enough for me. I did what I have to do to give sometimes maybe artery spasm, maybe he's hypotensive, maybe he's a vasopressor, you know. But I cannot leave the OR without Doppler signals. I have to have a signal. If there's no signals, it's different. If there's no signals, may I have to open below. Maybe I open the tibial dorsal. I try to do it from distal, you know, because sometimes I forget they cannot go distal because of occlusion, you know. Let's say none of them work, you may have to do distal bypass, you know, but this is rare condition. I doubt we have to go to this point. But the whole idea, you need to leave the OR with at least Doppler signals in one artery. This is the minimum you need.
Okay.
If you have signals in one of the artery, this is enough. You can leave the OR. Okay?
Okay.
All right. So you can give some like TBA, you can papaverine, because most of it be a spasm. Again, it's normal artery, they spasm a lot, normal artery, when you do thrombectomy. All right. What you do, not have pulse, if you clear all the clot, we said double signals. How would you manage this patient post-operatively? So what do you do after surgery?
I will give anticoagulation and antiplatelet.
Yeah, antiplatelet, yes, but the most important here is anticoagulant because this is an emboli, right? It's not thrombosis, emboli.
Yeah.
Then you have to do an echo for the heart if it's not done before. You echo the heart, put him in full dose heparin, and then you have to investigate what the reason for emboli is. Is the heart, it's hypercoagulability, it is COVID, whatever, you know, and then you have to plan him for long-term anticoagulant as a DOAC or warfarin. So you have to tell him that, you know. It's not the place for platelets here. Platelets for anticoagulation. Okay, patient does well, but 3 months later, he show up in the clinic with a small wound in the great toe. His ABI dropped from 0.9 to 0.5 since operation. Okay, something happened. So what do you do?
I will do for duplex ultrasound.
Duplex ultrasound. Okay. Do you want to see how is the artery?
Yes.
Okay. If they are open, if it's not open, if it's insignificant, and there's any clot there.
Yes.
So I think duplex ultrasound, it's very reasonable. Okay. Vision defense. Okay. Let's see what they did after that. Angiogram showed a long segment. They did an angiogram here. I don't know why they did angiogram. I mean, if you have to do CT angiogram, try to do something, you know. But first, I saw his arterial duplex.
Then CTA.
And I will look. Not really. I mean, because if I find like only SV occlusion, I may treat him as clodic. And he has a small wound. Sorry, he has a small wound. So you have to treat it. Yes. Then I'll get a CT angiogram.
Yes.
And then I'll do an angiogram. Okay. Angiogram showed long segment SFA and popliteal artery thrombosis. So the rethrombose again. reconstruction of posterior tibial artery at the mid-calf. How would you manage this finding?
Patient with big toe, grade 2 wound, a small wound, and SFA occlusion up to gluteal thrombus. Long segment. Yes. As patient is young and this recurrence disease, I will go for bypass.
Using
vein conduit.
Okay, but so what you should do first? You do vein mapping, right?
Vein mapping, yes.
Because it doesn't have vein, just have to decide to change your mind, you know.
Yes.
So you do long. So I agree. You see, this one you do long SFA polyartery is very long. So you have to do femdistal bypass to posterior tibial. Again, in real life, you can try again, but it's not in the exam. In the exam, I'll do femdistal bypass. He already thrombosed, you do thrombectomy, thrombose again. So the artery is thrombogenic become. So the best way to do bypass, I agree, especially has an ulcer, okay?
Yes.
So it's a good answer. Vein mapping short form intercalcification on post lobe extremity. Describe your operation. You have to tell him how to harvest it and do it. So you can do that, right?
Okay.
What if the patient does not have adequate vein to reach? What do you do?
Okay. I will order also Abraham vein duplex vein mapping.
Okay. Okay. You can use upper limb abscess. Okay.
Yes.
Or
prosthetic graft with cuff vein.
okay. It's cuff vein if it's not, you know. What if there is no vein available and the vascular option has been exhausted? Go allowed to do endovascular. So no vein, no endovascular, you do a graft. You said that, right? You do a graft with a vein patch. So
Yes.
what's the idea from vein patch to decrease the resistance distally? Okay. What other adjuvant maneuver can be performed to accomplish the same goal? What they mean? What other adjuvant maneuver can be performed to accomplish the same goal?
It means cuff or molar badge, cuff vein. I think it is if I'm using prosthetic graft, how can I make patent graft?
Maybe they ask you what other patch, like other patch, you can like as you has a Linton or Taylor patch or cuff or Miller cuff. Is the other one, you know?
Yes.
Yeah. I don't know about fistula. I don't think this fistula will help. All right. But if you do a graft, the patency is very bad. You know that, especially from distal. Yes. Is this something you worry about it?
If I don't have any other option, I will go with synthetic graft base, but I will try to do with vein badge.
Yeah, but patency is low. Maybe 1 year, they will not stay open for 1 year. So why you use it if you know patency is low?
I don't have any other option. I need to close the wound only. If wound
that's
closed,
correct.
And yes.
Yes, that's correct answer. Because I just want the wound to close. I don't care about long-term patency, right? You just need 6 months. So in this situation, you're not looking for long-term patency. You're looking for short-term patency. Just get the wound healed. If it's good later on, it's not a problem. So in this scenario, yes. If he doesn't have a wound, I will not do that. You know, like you don't use a graft, synthetic graft for rest pain because you need something more permanent. You know, but if you have an ulcer or wound, then 6 months is more than enough. Then yes, I agree with that. All right. Are you tired? You want to take one more case?
We tried to take one case because we already
exam, huh?
Yes.
Okay, so who's next? Who's the second victim?
Yes, I'm ready.
Okay,
Harry.
who's with me?
Harry.
Okay, let's go with this case. It's the last one. Let's go quick.
A 68 years old man who underwent an aorta bypass artery bypass 5 years ago for claudication present to clinic for his yearly follow-up. Over the past 2 weeks, he stated that has been having fever at night, sweat. The right groin is epistematous tender on palpation. and there is a small open wound over the scar that is draining a murky fluid.
Okay, so what do you think is going on with this guy?
Graft infection.
Yeah, it's graft infection, right? Okay, so the question now, what do you do next?
Start antibiotics and
Okay.
take a culture from the wound or sinus.
Do we have a sinus? Just a second, let me see the question.
Yes.
Son, he has been having fever, night sweat, the ankle tender palpation, and there is a small opening. Yeah, okay. So it is a sinus. Okay, so you take a culture. Okay. What else? You do an exam, right? Physical exam is very important.
Complete a physical exams and
Yeah, the pulses. I check the pulses.
the pulse.
It's very important because the graft is thrombosed. It's different than if you have patent graft, right?
Yes.
It's very important for you to know if the graft is open or not.
Yes. Yes.
So what do you do after that? So that's the next question. So there is no history in the groin before or groin issue before or weight loss. He denies claudication or symptom, critical limb ischemia. And his abdomen is non-tender. The right groin erythematous tender and murky drainage. There are palpable pedal pulse bilaterally. What you concerned about? We talk about graft infection, right? We talk about it.
Yes.
The next question, what workup you do in order to confirm you're suspicious?
First, we do ultrasound, superficial ultrasound.
Okay.
And then after that, we do a CT.
Why need a CT angiogram? You know, it's have a graft infection. So why you need a CT angiogram? And you know the graft is open.
To confirm or diagnose.
Okay. And second thing, you know, to know the extension, right, of the infection. You want to see any fluid, if it's dealing with only graft infection in the groin, or the whole graft is infected, like a lot of fluid around the graft, air bubbles, you know. So you have to decide, are we dealing with only groin infection or the whole graft is infected, you know?
Yes.
That's why I need a CAT scan. It's very important, okay?
Yes.
All right. And then you do WBC scan also, right?
Okay. Full
And
lab.
CRPT, yeah, you do full lab, CRP, ESR, you know, BMB, and WBC. All this have to mention to him. So you have to mention all the septic workup, and then you do a PET scan.
Yes.
Again, why a PET scan for what? Again, to see if the graft is infected. Are we going to light, if the whole graft lighted up, then the whole graft is infected. If it is just the groin, so PET scan is very important.
Yes.
Okay. So what you do like to do, we said about PET scan, we mentioned that. PET scan isolate infection of the right groin, okay? What the most common organism that lead to graft infection? Do you know what is that?
Staph aureus in early graft infection.
Okay, what else?
Staph epidermis if it is late.
Okay.
Or maybe candida.
It's very rare, candida. Okay. What else? E. coli, right? Don't forget E. coli, it's very common. The Staph aureus, epidermis, and E. coli is the most common. Candida is very rare. Okay, but culture came back Staph aureus. What is your plan?
Reconstruction of the limb and excision of the graft.
Yeah, but look, before that, imagine, again, it's an exam. So you tell him I started an antibiotic, because you see, if you don't say that, they presume, even though I know you do it, but the exam here going to presume, because he has a mark, you have to mark. Like if you said antibiotic, he give you 1 mark, you see? So tell him first, I start in broad spectrum antibiotics, or now you have a specific antibiotic, or we get a culture, get the right antibiotic first, and then I go and explore the patient. Before explore the patient, you have to do a workup, his heart, lung, echo, anesthesia clearance, and then you take him to the OR. Okay? So what's your plan? So what the next? His cardiac workup is negative. Describe your surgery. So how you do your surgery?
First, I do a reconstruction to limb to maintain blood supply to affected limb by FEM or X by FEM or XFEM. And
No,
then
just a second. So you're going to do, and in the exam, again, you don't give him two surgery in the exam, because in the OR, you cannot do two surgery. You have to decide, I'll do this one or this one. So tell me, I'll do whatever, FEM, axillo, FEM, what you plan? Tell me what you want to do.
FEM.
You do FEM bypass. Okay. How are you going to anastomosis to where? From the right to the left, you're going to go the same area is infected, so the graft will get infected. What's the advantage?
Kistra anatomical in SFA, in distal SFA from anastomosis.
So you go from the common femoral to the distal SFA.
Yeah.
You don't go through the groin. Correct?
Correct. No.
I mean, I think it's acceptable, but there's a better surgery, because this is a long graft. Don't remember, it may thrombose, very long graft. You're going from the common all the way to the, mid SFA. What is the other procedure you can do?
XFEM.
What's that?
Axillary femoral.
But why you need to go to axilla? It's very long graft. Why are you taking long graft? All long graft is nothing like short.
I don't know, but
You go from the limb, because remember, the infection only in the groin, correct? So the limb is not infected, right? Then you go retroperitoneal. Just some people talking. Maybe with everyone. Okay. So you do extranatomical, but you do it because the graft is not infected, only the groin. So most people, they go retroperitoneal, they do frank incision, and they do bypass from the graft to the SFA, going through the obturator foramen, right?
Yes.
It's called obturator bypass. And this is an important obturator bypass. And you have to know how to do it, obturator, through the obturator foramen. Because this way away from the groin. Because anything else will be very close. Even FEMPAP is going to cross the groin, so it will get infected. And they do axillofem is going to go through the groin. So the only way to go away from the groin to go through the obturator. Okay, foramen. So you need to go and read the approach, because he's asking you how to do it, and you have to know how to do it, how to explore it, how you do your tunneling between the retroperitoneal obturator canal to the SFA, and how you do your bypass. Okay. So after you do your bypass, you do end-to-end anastomosis with the graft, and you cut the graft and you ligate it, because this graft is going to come down from below. You can to pull it or leave it there. But you cut it and you do end-to-end anastomosis with the limb of the graft all the way through the operator to the SFA. But this is only if you open peritoneal and found no graft infection. And how you can tell that? You see the graft is well incorporated in the tissue. If you see the graft is like losing with the fluid around it, then it's infected. You cannot do this one. Then you have to take the whole graft out. Then you have to do axillo by FEM and like get the aorta or take it out and put like rifampicin graft. Then the whole thing changed. But if you go to peritoneal and the graft is clean, and you can tell that from CAT scan, there's no fluid in the retroperitoneal, the graft in the retroperitoneal is nice and not infected, then you go to peritoneal incision and you do graft to the SFA through obturator bypass. Okay?
Okay.
All right. So let's next. So what you do if you had initial planned and local explanation, revascularization, or encounter prolonged fluid and poorly incorporated bypass limb during peritoneal exposure. We just talked about it. If you open and you see fluid around the bypass, that means infected, then that's it. You have to stop and take the whole graft out, okay?
Okay.
But describe your surgery, how you take the graft out. You have to tell him a surgery.
We just after exposure of abdominal aorta, we just
So you go midline incision, right? You go midline incision.
get midline
Expose the yeah.
expose
Yeah.
the aorta and proximal control. Then
Yeah, but in the OR, in the exam, you have to do more details. You open the abdomen, how you retract the, you know, the tracheus coloncephalic. You get the bowel in the bowel back to the right. You identify a ligament of Treitz. You open it abdominal. You find the inferior mesenteric vein. You ligate it. Then you dissect. Then you find the femoral, the left renal vein. Then you dissect behind it. Then you find the renal artery. You see, you have to describe all the steps, okay, in the exam.
yes,
All right,
yes.
so you get there, you examine, you get there, and then you put your clamp.
And then excision of the aorta and double sewing the pump of the aorta
Below or above the renal?
below the renal.
Okay. And
And
then?
We excite the aorta, excite the
Okay.
graft from the
Okay.
femoral,
Okay.
and we irrigation the bowel, the abdomen by antibiotics,
Okay.
and then if you have a chance to reconstruction by autologous graft, we can do it. If I have, we can do just X by FIM.
No, tell me first option. What the first you said? What the first thing you do?
autologous
Graft.
autologous graft.
Yeah, but how you do autologous graft and you already close the aorta?
From proximal of the aorta by into side by femoral vein.
But you already no. You already, when you tell me in your description, you said you close the aorta. And then you decide what to do. You should not close the stump. You have to decide first. Are you going to put in situ or going to axillo bypass, you know? So you have to decide ahead of time. What's your plan? If you're planning to do in situ reconstruction, then you don't close the aorta. If you decide to do axillo byfem, then this has to be done even before you open the belly, because now you have an infected field. So if you decide to do axillo byfem, you do it first, and then you open the belly, you know?
Okay.
And then you excise it, and then you suture the stump. If you decide to do in situ, then you open there and then take it out. And in situ, you have many options. Most people now, they use rifampicin socked graft, but now more option to use a bovine. You make it like a tube. You can use a femoral vein, but if you're going to see that in the exam, you have to know how to do it. And I think we described that before. I know which lecture. We talk about how to harvest the femoral vein for bypass, or you can use a cadaver, you know, graft. This is all your option, okay? And then it has to be on lifelong antibiotic. Okay, patient is eventually discharged after a prolonged hospital stay. He presented to emergency department 6 months later with a fever, night sweat, 20-pound loss over the few months. Pseudoaneurysm at the proximal anastomosis. What is going on? So what happened now? So now he came. So after he did reconstruction with a rifampicin graft, now he came with a pseudoaneurysm.
We having a complete graft infection.
Okay.
And disruption of proximal anastomosis.
Say that again. What are you going to do?
Disrupted of.
Yes, but what's your plan? Yeah. So it has disruption on the anastomosis of the infection, right?
Yes.
So, and you did a PET scan and showed light up the proximal anastomosis. Blood culture positive for staph aureus, epidermis. WBC 18,000, and patient quite frail. How do you proceed?
We put it in proper antibiotics
Okay.
and put it in plan of follow-up because of epidermis is slow virulent and if pseudoaneurysm is small can no need for surgery. If it is affect all anastomosis, we need to reconstruction by other grafts.
Like what graft?
Like rifampicin soft graft.
But it was rifampicin before, and you already have an infected tissue. First, you don't say conservative. There's no place for conservative. This can rupture and patient can die. This is proximal anastomosis. It's very high pressure. So it has to be treated. If you tell him conservative, he will fail you because conservative management in this situation could be fatal, okay? So it has a pseudoaneurysm, proximal anastomosis, PET scan is positive, blood culture is positive. We have an infected pseudoaneurysm. It has to come out, you know? He's so fragile, already in situ reconstructions, not placed. So this one, you just do axillofem. You go there, take everything and suture the stump, okay? It's not placed for reconstruction. We cannot reconstruction. The tissue is so fragile, so infected. So this way you do axillofem by fem first. And then after you do axillo by fem, first always you do the clean surgery first. Then you open his belly, you take the graft out, and you suture the stump. Okay?
Okay.
And you take everything out. But don't leave him alone. All right. In the abdomen, the graft is this incorporated, and you have a few millimeters of infrarenal aorta left, but the tissue is friable. How would you close the proximal aortic stump? And ما في tissue. Sometimes they use the fascia from the prevertebra or some muscle. You can cover it, and you can use a plaget. You know, like a plaget suture. You know, with a plaget to fix it. It's very important. You don't get into the blowing up of the aortic stump. But most people, they use a prevertebral fascia and they flip it over to give more strength and take it with a suture to give more strength to secure the stump. But most mortality after this surgery come from blow up of the aortic stump. This was people die from that. I think, yeah, we're done with this. Any question about this case? Or the previous case, or any of the cases we discussed today, or any other concern?
Professor, I have a question.
Today? Yes, please.
In the first time of this case, why didn't we think about sartorius flap?
In the groin. I leave everything's fine, right? Leave everything's based on put sartorial.
Yes, from the start of the groin infection. Why we didn't think of reconstruction and sartorius flap?
Yes, I agree with that. First of all, you have to know that sartorius is good when for fempop, not for aorto by fem. You know that? Why? Because sartorius muscle cannot go up, can goes down. So usually anastomosis has to be low and going down. Then you do sartorius. When you have an aorto by fem infected, then you use the abdominal pectoralis muscle. Okay, you talk to the plastic surgery, they get you the pectoralis muscle and they do rotation flap and they do put it there. But sartorius muscle will not work for aorto by fem, it works for fempop. But why you didn't do it? Yes, I think it's a good options. I may do it as a first options, but in the exam, again, most probably you have to be on the safe side. I mean, you can ask him, but I'm afraid he may not like it. He wants you to take the graft out, you know. But
Okay,
in real life, it's a good options, you know. It's a good option. But again, remember, for groin infected, aorto by fem, you use abdominal pectoralis muscle, the abdominis. For sartorius, for fempop infected.
Okay, thank you, sir.
Okay. Next, any other question?
Yes, Prof. My question is, if I have iliac occlusion and I want to do ipsilateral. If it is necessary to do angiograph contralateral, or I can go with ipsilateral.
If you have an iliac occlusion,
yes,
you have to see your distal end. So you have to do an aortogram.
Okay.
Either from
contralateral or brachial.
Contralateral is what?
It's necessary I do angiography to the contralateral side in any procedure.
Not to the contralateral side. Angiogram to the aorta. You have to see where the aorta. Because if you have an occlusion, you want to see where your distal.
My question is, it is necessary to do contralateral side cannulation and aorta angiogram to see common distal end.
Yes, you need to. It's important. Either from the contralateral side or from the brachial. But you need to see your distal end. You cannot recannulate the common iliac artery without seeing your distal end, because you can end with a disaster. So you have to know where to stop. Like if you see the aorta end and your wire still not going back to true lumen, you cannot keep pushing up because end with dissection.
That's true.
So you try to push. When you get to the area where the aorta is supposed to be open, it's still not interlumen, you have to stop. But if you don't have an aortogram, you don't know where you end. So you keep pushing up, you end with a major dissection. So it's very important to know where you have to stop.
Okay.
Because you cannot tell from below. So it's very important.
Okay. Is there any possibility to, if I am done ipsilateral angiogram, I can see the end of the distal end or entry site? Can I see or?
No, you cannot see. If you do an angiogram from below, you cannot see it because of occlusion.
And if there is collaterals or?
Even the collaterals, the blood flow from aorta is very high and go down. So it's very hard. No way contrast scan goes up. It's different from venous. Even when the common iliac artery is occluded, if you shoot contrast from below, sometimes you cannot see the aorta if the flow is very high. Because you're pushing against the flow. So even if the common iliac artery open, sometimes you inject from below, you cannot see the aorta. Especially if you have common iliac artery is open and the flow is very high. You cannot see it. So you have to come from above.
Thank you.
You're welcome.
Excuse me, boss. One question.
Yes.
In first case, there is bilateral. Mentioned there is bilateral iliac lesion.
Okay.
One limb asymptomatic and other limb is symptomatic. We treat as symptomatic. Is it mandatory to do casing if the iliac lesion in other limb or symptomatic limb is proximal to ostium? Not at ostium.
It's a good question. I understand what you're saying. Yes, I understand what you're saying. If it's a complete occlusion, say, and the other one is symptomatic, other than that, asymptomatic. No, I just do symptomatic side would be enough. But if the other side is stenotics, most of you have to do a kissing balloon, because remember the disease, the common iliac artery comes from the aorta. So your stent has to go up to the aorta. So even if you do, like if the other side is normal, if you decide to go up to the aorta because of the disease, then you have to do a kissing stent. So when you have a flush occlusion in the common iliac artery, most of you are going to end to building two stents, kissing stent, because the stent has to protrude in the aorta, and if put in the aorta, it may cover the other side. The second thing, when you have a complete occluded common iliac artery, it's better to use a cover stent, because this is what the trial showed, that cover stent work better than uncovered stent for complete occluded lesion. So if you do cover stent, you have to be sure you have another stent on the other side, otherwise you occlude the other side. So again, you have to decide at the time of surgery, it depends how it's going to lay and if it's going to affect the other side. If you're opening this side, it will not affect the other side, which is asymptomatic, I will leave it alone. But if it's going to affect the flow, or if it's already disease like stenosis, then I'll do kissing technique. But if it's completely occluded, no, I will not try the other one because it'd be difficult to recannulate both of them. It takes a lot of time and no need for it. But if it's just a stenosis, then it's very easy. Just put 2 kissing stent and you're done with that.
Thank you.
Okay. Another question?
Yes, please, sir.
Mm-hmm.
In the last case, the patient was mentioned to have aortic bifemoral bypass for claudication. So, is there available for one of the management just excision of the infected graft without doing bypass if there is good collaterals and good physic flow? Or I have to say that I have to perform in the same operation another bypass?
No, not really. I agree with that. If it's just claudicant patient, but the problem, how do you know? I mean, during the surgery, they did for claudication, but the problem, the moment you did aortobifem, all this collateral now is closed. So if we just took it out, it may be collateral takes some time to open up. So you may end with a critical limb ischemia. So the second thing, if you take it out without reconstruction, I mean, it depends. If it's end-to-side anastomosis, it will be easy. But if it's end-to-end anastomosis, you don't want to leave it aortic stump or high pressure will blow up. So you don't want to take it out and suture the aorta. It's not a good technique. So if you have aortobifem done end-to-end, I think it's better to reconstruct it. It doesn't matter. But if you have end-to-side, then you may cut it, take it out, and wait to see if remove all infected tissue, and wait see how things goes. If it get worse, then you can do axillobifem later on. But this is again not for exam. In the exam, you have to be on the safe side. Okay. Again, exam is different from what you do in your real life. Kind of. I mean, you still do what you do in real life, but in exam, try to be on safe side. Don't try something heretical, something like controversial, something may not work. Always go to the something it really 100% work.
Okay, thanks.
But if you have like to go to infected and you have to close the stump and then do axillobifem, then you close the abdomen, you may wait and you see if it's good circulation, good collateral, you don't have the axillobifem. If it's had to get rest pain, you can do axillobifem. So you can argue this way.
Okay, thank you, sir.
Okay, any other question?
Patency of iliac stenting, Prof.
Sorry?
And follow up surveillance of the iliac stenting and after intervention of endovascular, would you go double anticoagulated or single anticoagulated?
Always with when you put a stent, you give dual antiplatelets, at least for 3 months, and then you can switch to single. But anytime you put a stent, it's better to put it in dual antiplatelets for 3 months, and then you continue with single. This is usually the recommendation.
Valency of stent and patency.
Sorry?
Follow up of the stent and patency.
I didn't understand the question.
How can you follow up the stent patency and the patency rate? How much?
Connection is not great. So you tell me about the stent patency, how to improve it, or how much the patency of the stent?
How much? Yes, how much patency rate of the stent, and how can I flow the stent patency by duplex?
Patency iliac stent is very, I mean, patency is very high. I would say about 80% for like 4 years. It's very high patency. It's very good stent. Follow up with ultrasound. I mean, you can see it, especially thin the guy and it's not and his MPO. You can do the ultrasound. If it's not, you can buy femoral. As far as good femoral pulse, patient asymptomatic, he's fine. So sometimes you can follow up patient with symptoms, but the best way by duplex ultrasound. You don't have to do CAT scan every time, no, because you can see it very easy with the duplex ultrasound, and you can measure velocity for follow up of stent.
Thank you, Prof.
Okay. Another question? All right. Thank you, guys. Hope we'll see you next week. Okay. You take care.
Thank
Okay,
you, dear
boss.
Professor.
Thank you.
Take care. Bye-bye.
Bye.